Dr. Andrea, would you like to give your talk?
Yeah, I hear you well. Okay, I'm here. I start with my presentation, so.
Yes, please share your screen now.
So I share my presentation. Okay, can you see my presentation? Do you hear me?
Yes, sir, I can hear you.
Okay. Hello, everybody. My name is Andrea Bartolo. I'm an interventional neuroradiologist. I work with Paolo in Neuromed, and I thanked Paolo for the invitation for this speech about radiological anatomy of ICA. And Paolo, in his speech, has talked about the previous classification of internal carotid artery. Now we will talk about a practical classification of internal carotid artery. Most of the images you will see in my presentation are taken from neuroangio.org. I recommend this site. It's a wonderful site about cerebral vascular anatomy. And we can divide ICA in several segments: the cervical one, the Petrous one, the Cavernous one, the transitional one, or Clinoid one, the Paraophthalmic one, a posterior communicating segment, an anterior choroidal segment, and a terminal segment. So we start with the first ICA segment, the cervical one. It does not present circulateral branches, except in certain anatomical variants, specifically the origin of ascending pharyngeal artery and the origin of occipital artery. Less rare are the so-called loops, which probably represent a sort of embryological remnant. This is an example of a loop of ICA in its cervical segment. And occasionally, the cervical segment may exhibit an anomalous course, a retropharyngeal course, in which the ICA runs anteromedially, passing posterior to oropharyngeal wall, as we can see in this image. Patient, in these cases, may report a sensation of throbbing of the throat. Another important thing about the cerebral segment of ICA is web. What is a web? A web is a shaft-like narrowing of the carotid lumen caused by not an atherosclerotic plaque, but an hyperproliferation of connective tissue. So they are currently thought to be a variant of fibromuscular dysplasia. In most of cases, they are not a serious risk of thromboembolic complication, but sometimes webs can lead to embolic stroke, or less commonly to hemodynamic stroke. In this angiographic view, we can see the difference between atherosclerotic plaque on our left side of the monitor and of web in the right side of the monitor. We can see the web as a sort of knife that cut the internal carotid artery of the origin, a shelf-like narrowing of connective tissue. Aneurysms of cervical segment of ICA are rare. In most of cases are typically this dissecting aneurysm or pseudoaneurysm. We can move on the next segment of ICA, the Petrous 1. It's located within the Petrous portion of temporal bone and in part within the lacrum foramen. The alternate artery enters into the cranial base, and we can divide this Petrous segment into three segments: the vertical Petrous 1, the horizontal Petrous 1, and the laterous 1. The first is vertical, has a vertical course. The second has an horizontal course and anteromedial course. And finally, the last segment, the laterous 1, has a vertical course. At this point, it passes beneath the petrolingual ligament. It's an important landmark that marks the entrance of the ICA in the cavernous sinus. Can you hear me? Can you hear me correctly? Okay.
Yes.
Okay, the petrolingual ligament is not visible angiographically, but we can imagine it with an imaginary plane passing tangentially on the Petrous portion of the top of the temporal bone, and we can use a landmark to locate it. We can see this imaginary plane tangential to the top of the temporal bone, and so with this imaginary plane, we can image the petrolingual ligament in this site. The Petrous segment of internal carotid artery may sometimes appear attenuated, so we can see in this image, due to the overlap of the Petrous bone, especially when compared with the uniform contrast enhancement of the intracavernous segment and of the cervical segment, but it's normal, it's not pathologic appearance. It's crucial to not mistake for an opacification defect due to thrombosis. Petrous segment aneurysm can be of two types, essentially, post-traumatic aneurysms and other types of aneurysms. Post-traumatic aneurysms are, in most of cases, pseudoaneurysms. They are generally secondary to fracture of a cranial base involving a temporal bone, leading to fissuring or dissection of the internal carotid artery. Other types of aneurysms include primarily white giant fusiform aneurysms. They are often thrombosed and frequently extend into the cervical segment of the internal carotid artery, but rarely they surpass the petrolingual ligament. When the surrounding Petrous bone is diffusely remodeled, the diagnosis is simple. We can do diagnosis even in a CT baseline scan. So this is an example of a wide giant fusiform aneurysms of the Petrous segment of the ICA, and we can see how the cranial base, the skull base, remodeled by this aneurysm. In this case, this aneurysm has been treated with a flow diverter stent. So we can move on the next segment. The anatomy of cavernous sinus and of the cavernous segment of the carotid of the ICA depends on the size and morphology of cavernous sinus itself, which is an extremely variable anatomy in terms of both dimension and compartmentalization. So we can see in this image the cavernous sinus and so the cavernous tract of ICA. The uncertainty in identifying the distal boundary of the cavernous sinus has significant in clinical interventional implication. Why? Because this is an important to determine whether a given aneurysm is purely intracavernous or, and therefore extradural, or paraophthalmic and potentially intradural. In the cavernous segment of ICA, we can see sometimes some collateral branch, such as in this case, we can see Bernasconi-Cassinari arteries, which is a dural tentorial branch. And sometimes we can see the pituitary blush. So sometimes we can see the meningophthalmic artery, meningohypophyseal artery, and sometimes tronchoinferal trunk. The aneurysms of the cavernous segment expand laterally into cavernous sinus in most of cases. This is an example of laterally expanding aneurysm of cavernous sinus. And the clinical presentation of aneurysms of cavernous segment of ICA are common, are known. They depend on what the cranial nerve has been compressed, and in case of rupture of cavernous segment ICA aneurysms, we can have a direct carotid cavernous fistula. This is another example of cavernous segment laterally expanding aneurysms. Another example, in this case, treated with a flow diverter stand with a good result. Sometimes we can have cavernous segment medially expanding aneurysms. In this case, we can have a remodeling of sphenoidal sinus, and in this case, we can have also a brutal epistaxis. We can move on the next segment of internal carotid artery, the clinoid or transitional segment of internal carotid artery. It's a very short segment located between the proximal dural ring and the distal dural ring, and it is the last extradural segment. We can see a microsurgical image of the clinoid or transitional segment of ICA. Neurosurgeon knows well this segment and this anatomical region because of they have to do an intervention on clinoid, anterior clinoid process for treating an ophthalmic aneurysm, an aneurysm of ophthalmic tract of ICA. But medially expanding aneurysm of this carotid segment represent a special category, often classified as carotid cave aneurysms. These aneurysms are located in a potential space created by the redundant reflex of the dura mater adjacent to the medial wall of the internal carotid artery. They are located at the same level of dural distal ring. However, they are considered to pose a potential risk of subarachnoid hemorrhage in some cases. This is a carotid cave aneurysm, an example. So we can move on the next ICA segment, the ophthalmic or paraophthalmic one. It extends from the ostium of the ophthalmic artery to the ostium of the posterior communicating artery. The great enigma regarding this segment is sometimes not always contain the ophthalmic artery. Classically, ostium of ophthalmic artery is located just distally on 1 millimeter from the distal dural ring. However, it may occasionally originate elsewhere, either distally from the dural distal ring, from the arterial cerebral artery, or proximal from the dural distal ring, such as clinoid segment, or a proximal dural ring, such as cavernous segment. This is a case of a lower origin of the carotid of the ophthalmic artery. Another example of lower region, in this case, cavernous region of the ophthalmic artery, and is an aneurysm of the carotid of the ophthalmic tract of ICA. Another example with the 3D reconstruction. aneurysm of this tract of ICA are very frequent. We can move to the next ICA segment, the posterior communicating one. So there are a lot of anatomical variants of origin of posterior communicating artery. We can have an hyperplasia of posterior communicating artery or a fatal cerebral posterior artery with hypoplasia or aplasia of P1 segment of a cerebral posterior artery. The next one is the anterior choroidal segment of ICA. This refers to the segment of internal carotid artery adjacent to the anterior choroidal artery. Unlike the posterior communicating artery, which sometimes can be sacrificed in some cases, the anterior choroidal artery must be preserved because it's a terminal artery. We can see the choroidal artery. The choroidal artery sometimes is not a unique artery, but sometimes is a group of small vessels, even 4 or 5 small vessels with the same function. The terminal segment beyond the ostium of anterior choroidal artery, a small terminal segment of the intermediate leads to its bifurcation. From the terminal segment can arise perforating vessels, transversing the anterior perforating substance and supplying blood to hypothalamus, the basal ganglia, and internal capsule. These vessels are in hemodynamic equilibrium with the perforating vessel arising from the arterial choroidal artery and with the group of lenticulostriate arteries. In these cases, a moya-moya disease, we can see an hypertrophic perforating vessel arising from the top of the ICA. And so the terminal segment bifurcates, like we know, in anterior cerebral artery and middle cerebral artery. And the aneurysms of this segment tend to project vertically or otherwise in another direction in the same direction of internal carotid artery. And this is an example of aneurysms of the terminal segment of ICA. So a complete knowledge of the neuroradiological anatomy of the internal carotid artery is essential for planning of neurosurgical and endovascular procedures. The identification of anatomical landmarks enables the prompt recognition of anatomical variants and supports informed therapeutic decision-making. The systematic division of internal carotid artery into segments serves as a useful framework for efficiently retaining critical information about this anatomical region. Thank you for your attention.
Thank you.